Early on in my career as a heart surgeon, I learned there was a link between oral health and heart health. People that have periodontal disease, those people are at higher risk of having heart disease. It turns out that insulin resistance is the primary driver of heart disease. Dr. Joseph Kraft, he looked at all the patients with heart disease, and what he found was 90 to 95% of them were insulin resistant. There's a couple of different pathways that connect the insulin resistance to the plaque and the damage in the blood vessels. The first one is the sugar problem. Insulin resistance lowers production of nitric oxide, an essential chemical that our body uses to help protect our blood vessels. I typically recommend starting with coronary artery calcium scan. All men, by the time you're 40, women, by the time you're 50, get your first scan. I have 30-year-olds ending up on my operating table. That means that disease started in their 20s. And so screening earlier can be helpful in certain situations.
How often are you scanning somebody middle-aged and finding no plaque?
The statistics are,
when it comes to hard plaque, soft plaque, is there any chance there for a reversal?
I think for both, the answer is yes.
The million-dollar question, somebody that gets a reversal, what are you having them do? Dr. Ovadia, when somebody goes low carb, keto, carnivore, somewhere on that continuum, and they don't get the health results they're expecting, what do you find is at the root of that?
Yeah, we need to understand that the human system is quite complex. And I never like to oversimplify things, right? So when we say go keto, carnivore, low carb, there's a lot of nuance that goes into that. And one of the things I think that has become most apparent to me now, doing this with patients in my practice for the past 6 years, is it's not just enough to focus on the food you put in your mouth. We have to really get into how your body reacts to that, how our body is processing that food. And this gets into issues like gut health, and bioavailability and nutrient density of those foods, to help us understand why some people react in certain ways and others don't, react in a different way. And that's what I've really come to learn over this time is the approach. We have sort of the general rules, eat real food, for instance, right? That can be applied to everyone, but there's nuance within, how your body's going to react and maybe some other aspects that we need to look at so that we ultimately can get the results that we're trying to achieve with that patient.
Okay, so say a hypothetical patient comes to you. We know we've got the check on the proper quote-unquote diet. And again, there's variability. There's different diets that can work for different people. But say they're still not getting those results. You named a few different variables there. How do you begin to uncover for that person what's at the root of that?
More and more, like I said, one of our focuses becomes your gut health. And simple questions like, how do you feel after you eat? Do you feel bloated? Are you getting heartburn? Do you feel energized or do you feel, tired after you eat? These are some indicators that we can use to determine if they have a problem with their gut health broadly. And what I really mean by gut health is you've put the food in your mouth, right? You got the input, the information that's in that food, the nutrients, right? That's what our bodies are looking for from food. And now we have to figure out, is your body able to properly utilize that? Is your digestive system working in a manner that we can extract those nutrients and we can then use them for, all the things that we need to use them for within our bodies? So starting with simple questions of, how do you feel after you eat? Looking at the quality of your bowel movements is another good indicator of what's going on with your gut. There is some testing that we can get into, but honestly, when it comes to gut health, the clinical scenario, right? How the patient feels and the signs and symptoms that they're experiencing actually go a lot further in informing us what's going on there than the testing does.
Well, let's talk about an ideal situation to understand how digestion works.
Yeah.
So somebody is sitting down to a ribeye steak. They take that first bite. Let's walk through ideally what happens in the body.
Yeah. So the first thing to understand about that ribeye steak is it is the most nutrient dense food that humans can eat. And what I mean by that is, if you want to look at this on a per calorie basis or per gram basis, right? The nutrients that are in that meat are really optimized for humans. And the other thing to understand about that meat is it's also the most bioavailable food to us as human beings. Over millions of years of evolution, for the vast majority of which we were primarily carnivores, meaning that meat was the majority of our diet, and our digestive systems evolved to be able to extract those nutrients from the meat. And we do not have the same reaction to plant products. The bioavailability of the nutrients that are in plant products are very poor. We're not optimized for that. So that's that's the reason that I advocate meat as the primary part of our diet. That's the reason I now tell people that meat is medicine. But so when things are working well, the meat goes in your mouth. Um, it starts to get broken down, right? And this actually, most people don't realize this starts in the mouth. We have enzymes and we have microbes, right, within our mouth that start to break down that food. And then it continues, it goes down through the what we call the esophagus, the food pipe, and then it gets into your stomach where things really accelerate, very highly acidic environment. And it's supposed to be a highly acidic environment. One of the most common reasons that we see people today having gut problems is because they've been put on, medications to reduce the acidity of their stomach. They might have had something like reflux, gastroesophageal reflux disease, and they were told that the solution to that problem is reduce the acid in the stomach. That's not how it's supposed to work. We were designed to have very acidic stomachs because that's going to help break down that meat and help break it down into its components, the nutrients, the amino acids, right, and the proteins, all of that, that are now going to make it easier for us to extract those nutrients. And then as it goes through the digestive system, without getting, too deep in the weeds here, right, we start to extract the nutrients that we need. We start to we get those proteins, those amino acids, we get the fats, right? Another thing that's very unique about animal fats is that it carries a lot of the important nutrients. We have what are called fat soluble nutrients, fat soluble vitamins that need to be in fat for our body to be able to access them. And that's why meat, and really meat alone, is what we are optimized to eat.
Okay, let's take this a little bit further. Once these nutrients get absorbed, they're in the bloodstream. Any other potential hangups on the way to the cell or within the cell?
Yeah, so one other thing I think would be good for us to bring into the conversation at this point is even before that, on the absorption part of it, there are what are called anti-nutrients. And anti-nutrients are things that are in plants primarily that might block the absorption of those nutrients. So, when you eat your meat alone, you're not going to get any anti-nutrients. When people are eating meats with vegetables, right, which people think that's a healthy way to do, have your meat, have your vegetables. And I'm not necessarily saying it isn't, but understand that some of those plants, some of those vegetables have what are called anti-nutrients, so that when they're in your digestive system together, that might actually reduce how much you're able to get out of the meat. And this is one of the problems that we see with eating things from the plant kingdom. Now, those same chemicals, these anti-nutrients, as they're absorbed into our system, they might be causing problems, elsewhere, peripherally, we can say, outside of the digestive system. But their primary issue is going to be within the digestive system. Now, once the nutrients are in your bloodstream and they're going around, yes, there can be issues with how we're able to use those. I think one of the common ones that we end up seeing, people may have heard about this, is what are called methylation issues, right? So, methylation is a way that our body, uh, some of these vitamins, for instance, the B vitamins in particular, right? They come into the system and they are in a form that is inactive. We can't use them in the cells and they need to be activated. And one of the ways we do this is what's called methylation, which is a chemical process that modifies those vitamins. So now our cells can use them. And some people, many people actually, have genetic variants that they're not good methylators. They don't do that process well. When people become insulin resistant, when people develop inflammation, that might even worsen. They methylate even worse. And therefore, they might be getting those B vitamins, but they're not getting the end effects that they need from them. And we might need to do something to help their methylation processes. That's one example of getting the nutrients in might not be enough. We then need to be able to utilize them and leverage them properly.
For that person that is having difficulty with methylation, what would that look like other than reversing the insulin resistance you talked about?
Yeah, so the first thing you want to do is things like reverse the insulin resistance, reverse the inflammation. But if that patient has a truly genetic block, right, that might not be enough. And a workaround in this case is you might need to supplement with the B vitamins in an already methylated form. And therefore, you're kind of bypassing the need for your body to do that methylation step.
For somebody that is unsure whether or not they're in that camp regarding methylation, is the methylated B vitamin safe for everybody?
Yeah, I think it generally is safe for everybody. Now, you can test your methylation, right? You can do genetic testing and get a sense of how well you're going to be able to methylate. More so, what we do is we look at one of the sort of byproducts of methylation. So, there is a blood test called homocysteine. This is one of those blood tests that kind of flies under the radar. Most doctors don't really know about it, they don't include it in the standard testing. What's interesting about homocysteine is when it is elevated, we know that associates with increased risk of many things, but primarily of interest to me is your risk of heart disease, your risk of high blood pressure, your risk of stroke go up when your homocysteine is elevated. Um, Homocysteine becomes elevated when we don't methylate well. And again, we'll try to not get too deep in the weeds, but homocysteine is an amino acid. It's in our bloodstream. It's not supposed to accumulate in our bloodstream. Homocysteine is supposed to get converted to other things, including another amino acid called methionine. It also gets converted to some of the neurotransmitters that we use in our brain. It's a very interesting molecule, amino acid. In order to do that conversion of homocysteine to these other things, the methylated B vitamins are what we call a cofactor. It's necessary to have enough methylated B vitamins around so that we can be converting to homocysteine. And so when you don't have enough methylated B vitamins, the homocysteine starts to accumulate. So this is an easy blood test that people can do. And it gives us an idea about how well they're methylating. You can also directly test genetically, test the genes that code for a lot of the enzymes that help with methylation. There's one called the one that we talk about most is what's called the MTFHR mutation. There's a couple of others. One is called COMT, COMT. These things can all be tested genetically, but usually the first step for me, for my patients, is we look at that homocysteine level. And if the homocysteine level is high, besides looking at things like inflammation and insulin resistance, we're going to start the patient on methylated B vitamins. And the vast majority of the time, that resolves the problem.
You brought up plant toxins. We'll get back to those shortly.
Yep.
But coming back to our ribeye steak example, I'm just trying to make sure I understand the different areas within that digestion, absorption, where issues can arise. The one that jumped out to me, you mentioned the stomach acid. I assume if people aren't producing enough, taking enzymes, taking HCl can help with that.
Yep.
But let's talk more to that piece and then others along the chain before we get to plants that can disrupt our body getting the nutrients.
Yeah, so besides the low acid problem, right, which is going to make if the stomach is less acidic, we're not going to break down, the meat or whatever we're eating as well, and that's going to then make it harder, right? Because the next step after it starts to get broken down is it now needs to get absorbed by our body, right? So keep in mind our gastrointestinal tract, right? Our digestive system. It is sort of, it is technically outside of our bodies, right? There is a lining, there is a barrier there, right? That guards against things that we don't want getting into our bloodstream. And regulates what can get into our bloodstream. And this is an active process, right? People sometimes get the misconception, right, that as long as the food is sort of sitting there, right, it's going to get into our bloodstream. But it turns out it is a very tightly regulated, very active process of what gets across that barrier and ultimately into our bloodstream and what passes through, right, and gets disposed of as waste ultimately in our stool. Um, when that lining starts to get disrupted, that absorption, the regulation of that absorption becomes a problem. And this is what we call leaky gut. We start to get, so the makeup of the wall of the intestines has these things, it's called tight junctions. The cells essentially are very tight against each other, and that is what blocks things from just passively moving through. When we get leaky gut, essentially those cells start to spread out. So now they're not as tightly opposed, and now we have a problem of some things that aren't supposed to get through start to get through, and the things that we are supposed to bring through actively aren't, properly bought through because there's dysregulation of this whole system. And so leaky gut, along with low acid, becomes another big problem that people get that is going to alter their ability to absorb the nutrients that we ultimately are looking for from our food.
I mentioned the enzymes, HCl. I know there's digestive bitters. Anything else in that realm for people that need help?
Yeah, so there are a lot of supplements ultimately that can help target this. There are all sorts of digestive enzymes outside of just the hydrochloric acid, and there are things like bile salts, for instance, that may be helpful for people that are having trouble absorbing fat in particular. Maybe you had your gallbladder taken out, right? And your bile system isn't quite optimized. But again, before we get to that stuff, right, we always want to go back to the root cause. And we want to say, why is your gut inflamed? Why do you have this leaky gut? And what can we do about that? Right. And the primary cause of leaky gut is going to be, again, the highly processed foods, the sugars, the highly refined carbohydrates, the vegetable and the seed oils, right, that are, lead to uh, inflammation within the intestines itself, and dysfunction of those cells, right, that are designed to be actively bringing the nutrients across. These things are all impeded by processed foods. Is really the big category I put in, and then in some people, things like plants, right, and those anti nutrients. Part of why they are part of how they work. Um, is by damaging again the intestinal lining and causing things like leaky gut. So that's why we have to have caution about some of those things. And ultimately, uh, when you really start to talk to people who are just eating kind of a standard Western diet, almost all of them have some level of gut dysfunction. They may not recognize it as such, but when you start to really uh, think about how common it is for people to say, "Well, after I eat, I get bloated, I get gassy, right? I get, my stomach gets distended." That is all, evidence of indicators of gut dysfunction. And it's just kind of accepted as normal within our society anymore. But it's not, it shouldn't be. And it's an alert that your body isn't working as it should be.
When it comes to leaky gut specifically, you just named a bunch of symptoms. Is that the best way to get insight whether or not we have that? And then you named a bunch of different insults, including processed foods. Is removing those enough to let that heal? Or do you recommend certain supplements or certain protocols?
Yeah, so I do believe that the symptoms are really the best way to get about this. There are some different tests that can be done. None of them really have, I think, proven themselves to do better than just asking about the symptoms in my practice. Ultimately, there are some situations where we might do the testing, but in general, it really starts with the symptoms for me. Um, the What to do about it, removing processed food is always the first step in my mind. Again, I always try and look at things like what can we do from a root cause approach before we start relying on things like supplements and pharmaceutical agents. Those may play a role. There are certainly situations where people have very severe gut dysfunction, and things like that might be necessary. You might need to go through a protocol, for instance, that is rebalancing the microbiome, right? Which is another aspect of this that we haven't gotten to yet, but I'm sure we'll touch on. And, that might involve some supplements. It might even involve some pharmaceutical agents. So those things can become part of the protocols. But the first step is always, if it's the food that primarily caused this damage in the first place, let's remove as much of the damaging food as possible, and give the body a chance to heal. Our bodies are miraculous in their capability to heal from lots of different things. But the first thing you need to do if you want your body to heal is you need to stop injuring it, right? And if on a daily basis you keep putting in these damaging substances, the processed foods, your body isn't going to have that ability to heal. And so that really is the first step for me always.
Coming back to the beginning of digestion, you mentioned it starts in the mouth, which before reading your new book, I always knew about amylase and the digestion starting there with starches, but there's also fat digestion that begins in the mouth too.
Yeah, again, our mouths are amazing, and everything that's going on there between the, like I mentioned, the oral microbiome, the bacteria that are in our mouth, that start some of this breakdown process, that start to produce chemicals like nitric oxide, which does so many amazing things within our body, and having the right balance of the right bacteria is important. So, one of the things that has become pervasive in our society that I don't think is beneficial are these mouthwashes, especially the ones that are, heavily alcohol based and other chemicals, right? And they're designed. The concept is, well, we don't want bacteria in our mouth, right? Let's try and kill as much of it as possible. But that's the wrong approach. There are bacteria that when they become, overgrown within our mouth, they're certainly harmful and they might contribute to things like cavity formation. But you don't want to go, wiping out the whole area, right? You don't want to like start, bringing out the napalm essentially, right, to your mouth. You want to eat the right foods that are going to feed the right bacteria so that you can have that good balance of bacteria in your mouth and they're going to start the digestive system properly. We then have glands, right, within our mouth, the salivary glands and others, right, that are going to be secreting some of the things like amylase that you mentioned, lipase, right, which is one that helps to start to break down the fat. And this is very important as well. And again, it is a finely tuned system, right? If you're not damaging it, it works great. But the problem is we start damaging it, right? We start damaging it with things like sugar. We start damaging it with the processed foods. We might unintentionally be damaging it when we use things like mouthwash, even certain types of toothpaste, right, that are going to, disrupt things there. Those can all be contributors. And then if you have something like periodontal disease that has now formed, right, that's going to magnify and amplify those problems. So oral health becomes a very important component of metabolic health. Now, what is especially interesting to me about this is, early on in my career as a heart surgeon, right, and during my training, I learned that there was a link between oral health and heart health, right? We know, for instance, that people that have periodontal disease, they have breakdown, of the gums. Oftentimes that's associated with having cavities and things like that. Those people are at higher risk of having heart disease. We also know that when you look at the plaque that forms in the arteries of our heart, you can see bacteria in there that live in our mouth, right? And, so conceptually, what's happening there is the bacteria from the mouth are getting into the bloodstream. They're causing the inflammation in the blood vessels, or they're contributing to it. And then they get trapped within the plaque that is a response basically to try and heal that inflammation. So I've always known that there's this, mouth gut connection. But I didn't realize quite how strong it was, right, until I started learning about things like metabolic health and learning about the oral microbiome and how it really influences things on many levels.
Okay, so we've gone over the mouth now, how to take care of it, how to support the microbiome. Let's move down to the gut microbiome now. Things we're doing that are having a negative impact and how to support that in a healthy way.
Yeah, so probably one of the biggest ones I see here is using antibiotics. Now, I want to be clear, antibiotics can be and oftentimes are, life saving things, right? Clearly, one of the, when you look back over the history of medical advancements, what has had major impacts on our improved health span and our improved lifespan. Antibiotics are clearly in that category. So I'm not telling people never use antibiotics, but the overuse of antibiotics, and this starts in childhood, right? Every time children have a ear infection, they get put on antibiotics when a lot of these things are viral and don't need them, and they just get overused, and they end up disrupting our microbiome. The push for shall we say, a cleaner society, right? Again, is something that got overdone. Now, clearly, again, we had benefits from improving our sanitary systems and all of that. But the fact now that every time, it seems you walk 5 feet in any public building anymore, right? And there's the dispenser of the antimicrobial hand gel, right? And so we're constantly doing this. The fact that we don't let our children play outside as much as we did, right? And, get play in the dirt, right? Which helped. Helps children to develop the proper microbiome. And so there are a lot of things that we are doing that end up disrupting our microbiome. So our microbiome starts off early in life less healthy than it should be, and then throughout life we're doing things to constantly kind of attack it indiscriminately, and that ends up causing a lot of trouble. The microbiome is essential to our health, having a properly balanced microbiome. Now, um, here's where things start to get a little muddy, because testing and understanding what's going on in your microbiome is difficult. We have lots of different ways these days, right? We now have these very advanced tests, right, where you can look at your stool and they can find the DNA sort of fingerprints of the different bacteria that are living in your colon. And we can get very detailed reports about all the distributions of all these different, types of microbes that are living in your colon. But we don't really yet have a good understanding of what healthy is and what unhealthy is. And one of the reasons that we don't yet have that understanding is we have preconceived biases that have gone into the interpretation of the results of these testings. So, when we started thinking about the microbiome, we said, well, we know what a healthy diet is, right? And that version of a healthy diet was, think the old food pyramid, low fat diets, plant forward diets, right? And we said, okay, the people that eat those diets more, this is what their microbiome looks like. So we're now going to basically make the assumption that that is the optimal microbiome. And it turns out that people that are eating meat heavy diets, right, carnivore type diets, their microbiome ends up looking a lot different than someone eating a plant forward diet. Um, and we've made a judgment that the plant one is better than the carnivore one, but we really don't have outcome studies yet, right? Do people with a carnivore microbiome have better results, less heart disease, less chronic disease, all of that stuff. Or maybe the people with the plant-based diet do, right? What we don't have those studies to that level yet. So it's still a little bit of a guessing game when you start doing all this microbiome testing, what the next step is. And that brings me back again to what we talked about earlier. I still kind of rely on the clinical symptoms there. If you're having issues with your digestion. And especially when we start getting into some of the symptoms that point more towards the colon and the lower intestinal tract, as we call it, that starts us getting thinking about things like the microbiome. And, maybe it's as simple as, you need a good yogurt that has a good balance of microbes that are going to help you reestablish a healthy microbiome. Like I said, the microbiome is still one area where we don't quite have all the answers yet, but we're getting there. And I'm hopeful that studies like, one that I just mentioned, right, where you can start to say, okay, this is microbiome A that tends to occur more in people on plant heavy diets. This is microbiome B on a meat heavy diet. Which one actually leads to better outcomes? Those are the types of studies that I'm hopeful we'll start to see in the future.
When it comes to these two different microbiomes based on the diet, are you aware of what those differences are? Is it to do with diversity, types of bacteria?
Yeah, it has to do with both of those, actually. And so, again, one of uh, understanding the complexity of the microbiome is another issue that we have, right? Because we're not just dealing with like 5 or 6 types of bacteria that can end up in your, end up in your intestines in different proportions. We're talking about thousands of types of bacteria, right? And you start to do the math of how many different combinations you can end up with, right? And all the different proportions, and that's a lot of data, a lot of noise, right, to start to find the signal within. This is one area, right, where, AI, large language models, right, those things might start to help us because they can go through large volumes of data efficiently and start to figure out the signal within there, because there is going to be a lot of noise when you're dealing with such a complex system.
If you talk to any dietitian these days, they're going to say you want to eat the rainbow,
Yep.
get a lot of different plants, a lot of fiber.
Yep.
That's going to cause the diversity of the microbiome. I assume by what you're saying here, that's not your stance.
Yeah, correct. That is not my stance at all. As many people know, right, I am a proponent of a carnivore diet. And I have, me personally, lots of people that I work with, lots of patients that I work with, right? We consume very little to zero fiber on a regular basis. And I can say my gut health is better than it's ever been. My overall health is better than it's ever been. So the concept, simple concepts like we need fiber, those should be questioned. When you really look at the literature around fiber, the scientific literature around fiber, what you see is if fiber is displacing processed food, junk food, you demonstrate a benefit from that, but you can't really demonstrate that there is benefit from the fiber itself. I would argue in those cases, it's taking away the processed food that's really leading to the benefits. The most interesting thing about fiber that most dietitians, most doctors don't realize is um, the best study that I'm aware of that was done looking at what we call idiopathic constipation. So constipation that didn't have an obvious cause. Um, and they did a study, a randomized controlled trial, where they gave some of the patients with that fiber supplementation, and then they had the group that didn't take the fiber supplementation, and the constipation got worse in the group taking fiber. So fiber does not help with one of the most common problems that we're told that it helps with, constipation. And I think the benefits of fiber in the diet are largely overstated. I do not consider it to be essential. And of course, the whole plant forward, eat the rainbow concept is another one that I take issue with.
You mentioned there again the difference between a plant based microbiome versus a more carnivore-ish. I'm curious, obviously, carnivores have a microbiome, although it's different.
Yeah.
What is it that's feeding that? Do the muscle meats feed that? Some of the other parts of animals, the gristly parts? Any thoughts on quote unquote animal fibers?
Yeah, so exactly right. It turns out that there are essentially equivalents of fiber that occur within the meat. And a lot of this is like kind of the connective tissue type stuff that, is in the meat. And it's in all cuts of meat, right? Ground beef is going to have lots of it, but even within a steak, right? You think about those connective tissues that are in there, and that seems to be a primary fuel for microbes in the gut. And it is, I have kind of started to think about it. And we mentioned in the book that is basically an animal form of fiber. And that's maybe why people on carnivore diets don't need fiber to maintain their gut health.
You mentioned yogurt there. How do you feel about fermented foods in a broader sense? We have kefir, fermented vegetables, probiotics.
Yeah.
Talk more about how you think about reseeding the microbiome if it's been damaged and for maintenance.
Yeah, so I think fermented foods broadly can be a good tool to use when you're trying to improve your gut health. And whether we're talking about, fermented dairy or fermented um, plants or even fermented meat. There are fermented meats that traditionally, ancestrally, were part of the diet and remain part of the diet in some cultures. Um, it's interesting when you look at the plants. Um, the new book, Stay Off My Kitchen Table, the foreword to it was written by Bill Schindler. Dr. Schindler is a anthropologist who has studied kind of food history, how we came to eat the things that we eat, and specifically looking at, for instance, plants, right? And when you go out in nature broadly, um, a large proportion, I forget the exact number, right? But it's something like 95% of the plants as they occur in nature would kill us if we ate them, right? They are poisonous to us. And one of the things that human beings were able to do over time is figure out how to detoxify enough of these products, right, that they could eat them, right? And that's agriculture essentially. And one of the methods that is used in traditional cultures is fermentation. And it turns out if you ferment plants, you can detoxify a lot of the issues that come with plants. And so the fermentation process is very fascinating. And I always tell people, if you're going to incorporate plants into your diet, fermented plants are probably one of the best ways to do that. But it's one of the things I put in the category of, if you're having gut problems, you probably, fermented foods can be a great tool to use to heal that. I'm not totally convinced that fermented foods are necessary, as a maintenance thing for people. They're not harmful. If you like them, if you want to eat them, great. But I know plenty of people that do carnivore diets, for instance, that don't incorporate any fermented foods, and they're still doing great. So I don't think it's a necessity, but they can be a tool to help with all of this.
What are your thoughts on probiotics?
In terms of the supplements, that get
Yeah,
sold with
capsules,
probiotic,
powders.
yeah, I'm not a big fan of them. Again, I don't. I think many, maybe most of the ones that are out there, the reality is that the bacteria counts, are not high enough to really impact our gut and our gut health, and they don't get absorbed. They don't survive through the digestive tract like we think they will. So probiotics are not something that I recommend broadly to people. Again, I think if you're targeting certain aspects of heart health, of gut health, um, fermented foods, probiotic type foods can have some benefit there, but I'm generally not a fan of the probiotic supplements.
Let's come back to plant toxins and start really broad here.
Yeah.
What are some of the healthy fruits and vegetables people are eating, quote unquote healthy, that are actually causing problems?
Yeah, I think most of them actually could be put in that category, to be honest. And again, it's going to depend on the person, but let's take broccoli, right? Broccoli has a host of anti-nutrients in it. Spinach is another big one. Spinach, kale, right? These are loaded with something called oxalates that, again, are damaging to us, can contribute to that leaky gut forming. Oxalates form crystals, right, that can be thought of as basically daggers, right, that start to damage the gut, and they can get into our joints and start to contribute to things like, gout and other inflammatory sort of joint disorders. So most of the plants, right, understand the reasons that the anti-nutrients are there is it is the plant's defense mechanism. Plants don't want to get eaten, right? Um, Broadly thinking about life on this planet, right? Every species The goal of that species is to continue to propagate, right? You want to be able to reproduce and make sure you persist. Um, Animals, right? Our defense is animals can run away, animals can fight, right? So that is how animals defend themselves. Plants can't. Plants can't move. Plants can't really defend themselves in that physical manner. So the plant defense system that evolved is if when an animal tries to eat the plant, that animal gets sick, right? The rest of that animal pack, animal tribe, is going to learn, don't eat that plant. And these defense chemicals, right, these anti-nutrients, these toxins like oxalates and other things, are how the plant defends themselves. And we have to realize as human beings, our intestinal tract, our intestinal system can't deal with that. Now, what's unique about some animals, especially the ruminant animals, right? They can deal with those defense chemicals. They can actually start to detoxify them. And therefore, they are more adept at and more designed, you can say, or have evolved to be able to eat the plants. The ruminant animals extract the nutrients from the plants well, and those nutrients then end up in the meat, in the fat of that animal. And we as human beings are designed to then eat the animal, and that's how we get the nutrients from the plants. We were not designed, we are not optimized to get the nutrients directly from the plants.
When you were talking about fermentation, you mentioned the fact that it can help with the toxicity of some of these plants.
Yeah.
Any other methods of preparation people can use to have that same impact?
Yeah, all of the really, cooking methods that we came up with, right, for plant products, and it can start with things like soaking and sprouting, and then just cooking in general, right? These are all ways to help detoxify and also help to start that breakdown process, right? When we went back to the basics of digestion, right? Again, the types of enzymes that we have within our digestive system are not optimized to break down plants. They're optimized to break down animals. So we have trouble in a lot of cases breaking down the plants. And when you start to soak something and sprout something and cook something, that starts that breakdown system. So now we can, eat these plants and start to extract nutrients. So again, Dr. Schindler is probably the best resource in the world. I would point people to his book called Eat Like a Human, where he really goes into it took a lot of work for our ancestors to figure out how to make enough of these plants not at least overly toxic to us. But there are still some persistent low-grade toxicities that, again, we don't fully recognize all the time, that end up contributing to this.
For somebody that wants to include plants in their diet, at least right now, what would you say are the safest of the ones people are eating?
Honestly, I think that's going to depend on the individual. And this is where I utilize the carnivore diet as a great elimination diet, right? Because when we reset the system, when we take all of the plants out and, you give it 30, 60, maybe 90 days of doing that, and you get to what is, for most people, sort of an optimal state. And then you can start to selectively add things back in. This can be a good way to figure out, what you react well to and what you don't react well to. This I find to be particularly applicable for people that are dealing with things like autoimmune conditions, dealing with the gut dysfunction, the leaky gut. One of the powers of the carnivore diet is it is the best elimination diet that human beings can do. Again, meat is the simplest food that we can exist on. And so, you kind of do a reset with it, and then you can start to figure out what plant products you react to and what ones you don't. And for a lot of people, the reality is that, probably most fruits and vegetables are okay to eat in some level. Um, However, uh, they are not essential to human health. The one of the big, kind of messages that I aim to get out to people is the carnivore diet is a perfectly valid dietary approach for human beings. Meat is medicine, I tell people, and meat is actually essential to health. The plants are optional. Some people tolerate them just fine, and if you enjoy them and you wanna have them and you're tolerating them well, then I tell people, "Go ahead," they are a whole real food, and so they fit in my kinda, high level schematic of what we should be eating, whole real food. But they are not essential. This messaging that we have gotten, that you need your veggies, that certain nutrients are only available in plants is just not true. Human beings can get every essential nutrient that they need from meat and meat alone, and there is nothing unique that are in plants that we cannot get from meat. The opposite is not true, by the way. Plants do not have all of the essential nutrients that we need, and that's why people that are doing vegan diets, they need to supplement to remain healthy. Um, Carnivores do not. So ultimately, like I said, I put the plants in the category of if you want them, for a lot of people, they're not going to be harmful, and you can feel free to eat them. Uh, there are a fair number of people, though, that they are harmful, and they can be subtly harmful, and you need to acknowledge that. And you need to be pretty selective about what you're putting in, and you need to ask why. Why are you putting it in? Because if we start with the basic thesis, right, that the reason we eat is to get the nutrients that our body needs and to get the building blocks that our bodies need. And we can get that all from meat, which we can, and we can optimally extract it from meat, which we can. Then why are you putting the plants in? Right. And it becomes a very different conversation about how we're constructing our diet.
Are you currently consuming any plants on a regular basis? And if so,
No.
why?
No, I'm not. Like I said, I maintain and have maintained now for a long time a carnivore diet. The vast majority of what I eat is from the animal kingdom only. Now, the reality is that I don't react negatively to plants generally. I can eat them. I just don't choose to because I'd rather have the most nutrient dense product, and a carnivore diet has just worked great for me, so I continue to do it. But yeah, there might be a situation where I have an occasional plant product, but it's not something I do on any sort of regular basis.
You talked about people using this carnivore diet potentially as a reset. For somebody wanting to do that, what are the initial carnivore foods that they would want to allow? And then how long till they start introducing other things?
Yeah, so again, the simplicity of carnivore is one of the things that I like most about it. It's real kind of black and white. If it comes from an animal, it's part of the carnivore diet, right? So these are going to be your meats of all kinds. These are going to be seafood, I include in there, and these are going to be eggs and dairy products, right? That come from the animals, and that's what you include on a carnivore diet. And if you're doing a very strict version of a carnivore diet, you're not going to have anything else beyond that, right? You may not even use things like spices that comes from plants. Now, again, do most people need to go that extreme? Probably not, but some people do. And I always encourage people, to start with a 60-day trial. I think that's a good amount of time to start to really, and again, a lot of this is about what you're not eating, right? The processed food and getting that stuff, the effects from that all sort of flushed out of your system is a way to think about that. So 60 days, I think, is a good thing. Some people, they say, well, I can only do 30. So I'm like, okay, start with 30. And at the end of 30, they're usually like, you know what, I'm feeling pretty good on this and I can do this. So I'm going to go 60, 90 days, right? Whatever it might be. And then, like I said, you really get a baseline of how good we're supposed to feel. One of the very kind of insidious things that has happened in our society is most people don't actually understand what good feels like. I mentioned earlier, we've become accepting of things like it's just normal to be bloated after you eat. It's normal not to have full energy. The little aches and pains that starts to sneak into life for many people, right? And everyone says, "Oh, well, that just happens when you get older." It's not the way it's supposed to be. We are supposed to be able to function optimally, well into our lifespan. And we've lost the appreciation of that because, quite frankly, we look all around us, and everyone else around us has these things, and so we say, oh, well, it's normal. But it turns out you don't need to have those things. And, eating a carnivore diet can be a great approach to show you how good you're supposed to feel. And then you say, okay, I miss whatever it might be. I'm going to try reintroducing it. And I encourage people to do that kind of systematically, pick one or two things at a time and, reintroduce it for a week or two. And if at the end of that time you still feel that same optimal level that you felt without it, great. Your body tolerates it. You can incorporate it. But if you don't, if you start to notice, oh, that ache and pain that had gone away, all of a sudden it's back, that's the signal that your body is not reacting well to that food and you don't want to incorporate it. Now, within the carnivore framework, are there things that some people do not react well to? The answer is yes. And dairy is probably the big one here. Some people, dairy is problematic to them. And I'll oftentimes tell them, you might want to start your carnivore diet without the dairy. Now, dairy is interesting in that a lot of the people who have negative reactions, right? They'll say they're lactose intolerant, they're dairy intolerant. It turns out it's because of that underlying gut inflammation. And if you give a carnivore diet a chance and you heal up the gut inflammation, I have had many patients who said, I can't tolerate dairy. They go on the dairy-free version of the carnivore for 30, 60, 90 days. And they then reintroduce dairy and they tolerate it just fine. Because it wasn't really the dairy itself that was the problem. It was this leaky gut that was altering, the proteins and stuff that got across that barrier that was causing the problem. And the gut healed, and now they can tolerate things like dairy, which has been a very interesting phenomena, like I said, that I've observed multiple times now in my patients.
For somebody with gut issues, can you think of a better way to heal the gut than going carnivore minus the dairy for that 30, 60 days?
No, I really can't at this point. Clinically, I haven't seen it, and like I said, there are lots of protocols and stuff that are out there and people go through and they do these, the cleanses, right? We hear about, and I have not come across anything that performs as well as a carnivore elimination diet.
Somebody who is now excited about this, they're on a standard type diet right now.
Yep.
They make the switch. They do it pretty extreme and go right in.
Yep.
What are some of the things you want to give them a heads up on that they might experience changes in their body?
So the first thing to understand is if you're coming from a high carbohydrate diet and you're going to a low carbohydrate diet, there are important hormonal and biochemical changes that are going to occur. So, for instance, your insulin level starts dropping And one of the things that happens is that alters within the kidney how you're handling electrolytes, things like sodium. And initially, as your body is making that adjustment, you're going to lose more sodium in the urine, and you need to replace that. So this is why we usually advise, salt on your food, good high quality sea salt, and a lot of people need to supplement with electrolytes. And sodium and magnesium are probably the two biggest ones. So salt. Maybe using a magnesium supplement. There are lots of kind of those electrolyte supplements out there, and those are oftentimes necessary when you're first transitioning from a high carb diet to a low carb diet. And of course, a carnivore is going to be a very low carbohydrate diet, essentially a zero carbohydrate diet. So that would be the big one. The other thing that people need to understand is that your primary energy source that your body is going to use is going to be shifting from sugar, right, to fat. Um, and you need to account for that. So having enough fat in the diet becomes very important. And again, most people, right, our whole lives, we've been programmed against consuming fat. So people go on the carnivore diet and they're like, well, I'm going to eat my lean chicken breast, right? I'm going to eat my lean cuts of meat only. And they don't recognize the importance of, no, we actually need that fat. That's our energy source now. And that's another common area where I see people kind of get tripped up initially.
How does that change as a person is on this diet longer? And the reason I ask that, somebody coming to it, oftentimes is going to have a lot extra fat on their body.
Yep.
Is it early on the body is not good at pulling that fat and using it as energy, so we have to bring it in through the diet?
Correct. And this specifically has to do with the effects of insulin. So we think most people, when they think insulin, they think, okay, insulin is there to get the sugar out of the bloodstream, lower the blood sugar level. And yes, that's something that it does. But one of the things that they don't recognize is when your insulin level is high, it blocks your body from accessing the body fat, from pulling the fat out to use for energy. So again, people that are coming from a high carb diet that have high insulin levels, they're probably insulin resistant. They may be diabetic, right? Type 2 diabetes, that's the basic biochemical thing in type 2 diabetes is your insulin level is high, and therefore your body is blocked from accessing your body fat. And that's why you're going to need to eat high fat um, to give your body that energy. Now, after an adaptation time, right, your insulin level has now come down because you're not eating the carbohydrates. Now you might not need quite as much fat in your diet. And now we can let our body start to burn that body fat, right, which is what most of us want and need to do. And so oftentimes, as people are, getting settled in on their carnivore diet, we might have them, lower the fat some. You never want to go very low fat because, again, like I said, the nutrients in many cases are stored within that animal fat. It's essential, right, to get the nutrients from that standpoint and to have some fat to use for energy. But, many people can kind of back off a little bit so that we can start burning more of our body fat.
How do you think about ketosis? For yourself, other people eating this way? Is that something you're naturally going to fall into? And then is that important?
Yeah. So, yes, you're going to naturally fall into it. When you eat, when you're not eating carbohydrates any longer, your body is going to get to burning fat and you're going to start to make some ketones. Now, you may not make a lot of ketones. And everyone always asks, is that important? Should I be testing my ketone level? Should I be looking at your ketone levels? And again, the answer ultimately becomes, well, it depends. It depends on what your goals are, what you're dealing with. There are certain conditions where being in higher level of ketosis, having more ketones in your bloodstream, is clearly beneficial. The three big ones that I always point people to for this are um, neuropsychiatric conditions, right? So again, think back. The first use of a ketogenic diet clinically was to treat seizures, treat epilepsy in children. So obviously, it must be having some sort of effect on the brain. We now, over the past couple of years, have realized what a major impact ketones have on the brain. We have a new field called metabolic psychiatry, where there are amazing people out there like Christopher Palmer, like Georgia Ede, and so many others that they are treating advanced psychiatric illnesses like schizophrenia, depression, bipolar disorder with ketogenic diets. And they're having amazing results. They're getting people off of medication, off of these powerful antipsychotic and, other psychiatric medications with just changing diet. So, brain conditions, neuropsychiatric conditions is number one. Heart failure is another area where having higher levels of ketones have been demonstrated to be beneficial. It turns out that the heart loves ketones. Many people don't realize that there is a direct connection, anatomic connection between our intestines and our heart. There's a structure, it's called the thoracic duct. And what that does is part of the fats that we eat, right? The first place they go is right to the heart. They bypass the liver. And they do this because the heart loves fat as fuel. It loves ketones as fuel. So patients that are dealing with impaired heart function, heart failure, they can benefit from ketones and having higher levels of ketones. And the third condition that higher levels of ketosis may be beneficial in is as an adjunctive cancer therapy. And so those are a couple of the situations where I tell people, yeah, you probably need to test your ketone levels and you may need to adjust your diet in such a way that you can get those real high levels of ketones. People that are just kind of going for general health, weight loss and those types of things, probably not as important. It can be beneficial. Some people find it useful to do that as a kind of guide to help them determine, ultimately, right, if you're on a carnivore diet, the only macro variability, and I'm talking about the food macros, right? The macro variability is going to be how much protein versus how much fat. And, and that's going to determine how much ketosis you ultimately get into, how much, what level of ketones you ultimately generate. And so, in some situations, paying attention to that and testing it is useful. In a lot of situations, it's not.
So it sounds like it when it comes to carnivore and people that aren't producing the ketones like they would like to, that's because of the up protein and this protein bolus that's going to cause gluconeogenesis. Is that right?
Correct. So, our bodies can convert protein to glucose to make energy. It's not a preferred way for our body to make energy. It turns out that it's a fairly inefficient way to make energy. But if our body doesn't have a choice, it's going to do that. So again, if we're in a situation, for instance, where there's, someone is insulin resistant and they're not accessing their body fat well, and they're not consuming enough fat, the body's going to take the protein that they are consuming and it's going to do gluconeogenesis, convert it to glucose, and use that for energy. And in a situation like that, I may be advising people, okay, you want to back off the protein some. Again, we're not going low protein. And you want to start adding some more fat to your diet so that we can get you into, a more ketotic state, more ketones, less glucose as our fuel source.
So it's obvious you're not fearing fat.
Yeah.
But for the average carnivore who isn't seeking ketones, how do you feel about adding fats to things like a ribeye, putting butter on top, adding heavy cream to coffees? Is that something you ever advocate for patients or something you do?
Well, I basically tell people to kind of titrate your fat intake to your energy levels, right? The way that I kind of start to construct carnivore diets with people is, okay, let's set your protein goal. Let's figure out how much protein you need. And again, my starting point is usually around 1 gram of protein for each pound of lean body mass or ideal body mass that you're kind of targeting. So, you know, and again, for most people, that's going to fall somewhere between 100 to 150 grams of protein a day as a rough starting point. Um, and then I tell people, eat the fat that comes with it, right? And, again, I tell people, don't fear the fatty cuts of meat. You don't have to have ribeyes all the time. You can, but, you don't have to for most people. Do a kind of mix and, you'll end up at a certain fat level and then see how you feel. And if you feel like your energy levels aren't adequate, if you are someone who is targeting higher levels of ketones for maybe one of those reasons we discussed earlier, then yeah, start adding more fat. Now, some people from just a enjoyment perspective, right? They want to add a lot of fat at the beginning, and I usually don't discourage them from doing that. But if they then reach a point, and this comes up most commonly in the context of people are trying to lose weight and they're like, I went on my low carb carnivore diet. I lost a bunch of weight at first, and then it kind of stopped, and now I'm kind of stuck, or maybe I'm even gaining back a little bit of weight, and that's usually where we'll start looking at, well, how much of the extra fat are you consuming? Are you putting more butter on? Are you putting a lot of cream or even butter in your coffee? Which is popular. And maybe, that's an area we want to start to back off of a little bit. Like I said, I don't tell anyone you need to be on a low fat diet. I really, I can't think of a situation where I've recommended a lean carnivore diet, right? You do need the fat, you do want some fat, but yeah, like everything in our society, sometimes that gets taken to the extreme and everyone thinks they need every meal needs to be a ribeye with a lot of butter on it, and they need to be drinking all sorts of heavy cream in their coffee, and most people don't need that. Most of us have the body fat, right, that we can, when we're able to utilize it, we should be utilizing it.
Insulin resistance is something that's come up a few times. Let's go
Yeah.
into greater detail on what that is and why somebody might have it and not even know.
Yeah, so first of all, what it is, right? So, uh, when we eat carbohydrates primarily, uh, our insulin levels are going to go up. And the reason we mentioned it earlier is you eat the carbohydrate, gets converted to glucose, to sugar. That sugar goes in our bloodstream, and our body knows that too much sugar in the bloodstream is toxic. So we don't want to let it hang around. And insulin is the primary hormone that gets the sugar out of our bloodstream. And the way that it gets the sugar out of our bloodstream is either we're burning the sugar immediately for energy, or we're putting the sugar into storage. And we have what's a short-term storage system. It's called glycogen. That can go in the liver and that can go in our muscle. And then we have the long-term storage, which is fat, body fat. And, so that goes into our fat cells. Now, if you're eating too much carbohydrate and you're eating carbohydrate too often, your insulin level is going to remain elevated. And the cells, right, the fat cells, the liver cells, the muscle cells, right, that are taking in all of this sugar, they're going to get full. They're going to say, can't take in any more sugar. And they're going to stop listening to the insulin, essentially. And that's what insulin resistance is. And the body's initial reaction to that is, okay, well, we're just going to make more insulin and, kind of force these cells to listen. And that might work for a while, but then it's going to stop working. And finally, what's going to happen is your blood sugar level is going to remain elevated, right? And that's where most doctors pick up on the problem. All of a sudden, you're diagnosed with diabetes. And the problem is they've missed the long period of time, often decades, that the insulin was high, the body was becoming more and more insulin resistant. And during all that time, there's damage being done. There's damage being done to your blood vessels. There's damage being done to your other organs. And it's a huge missed opportunity because if we just do a very simple test, look at the insulin level, look at what's called a fasting insulin level. You haven't eaten for 8 to 12 hours. How much insulin is in your bloodstream? And if it's a lot, and I consider anything in double digits to be a lot when you're looking at the test results, it tells you you're on your way to you're insulin resistant or you're on your way to insulin resistance, and we got to do something to reverse that.
As a heart surgeon, talk more to that piece about high insulin and damaging blood vessels.
Yeah, so it turns out that insulin resistance is the primary driver of heart disease. We can go back to some studies done primarily by Dr. Joseph Kraft, 1970s, 1980s. And he was one of the, leading clinicians and scientists looking at insulin resistance. And one of the things he did was he looked at all the patients that came into his hospital with heart disease, with heart attacks. And he screened them rigorously for insulin resistance. And what he found was 90 to 95% of them were insulin resistant. So heart disease is insulin resistance primarily. Now, you contrast that against what we've been told more recently is the cause of heart disease, cholesterol, right? And you look at those statistics, the patients that come into the hospital with a heart attack, how many of them have high cholesterol? And it turns out that's like a 50-50 shot, right? Maybe half of them have high cholesterol versus, like I said, 90 to 95% that have insulin resistance. So which ones should we be focusing more on? Insulin resistance. Insulin resistance is the root cause of heart disease. And I believe our path forward, if we're going to have meaningful impact on heart disease, is let's attack the insulin resistance. And that's really been the primary thing that I have been doing with patients now to try and manage and prevent their heart disease. And we are seeing great results from it.
Let's get into the mechanism there.
Mhm.
Somebody with circulating high blood glucose, high insulin, how does that cause plaque in the vessels?
Yeah, so there's a couple of different pathways, right, that connect the insulin resistance to the plaque and the damage in the blood vessels. So the first one is the sugar problem, right? Sugar is directly toxic, directly damaging to the lining of our blood vessels. And so as you're becoming insulin resistant and you're not controlling your blood sugar level as well, and you're starting to get these spikes in your blood sugar, every time you eat, that's going to directly damage the blood vessel wall. And that's the first step in the plaque formation process. Now, insulin resistance does a couple of other things that magnify that problem. Insulin resistance lowers the production of nitric oxide. Nitric oxide is a essential chemical that our body uses to help protect our blood vessels. Nitric oxide helps lower our blood pressure, does lots of things, but it protects the lining of our blood vessels from damage. And when you get lower levels of nitric oxide, you're now more prone to damage to the blood vessels. And it turns out that insulin blocks one of the enzymes that our body uses to produce nitric oxide, and therefore insulin lowers nitric oxide levels. The third important way that we start to connect insulin resistance and plaque is that insulin resistance actually alters the types of cholesterol that we have in our body, right? And this gets into the discussion around um, cholesterol, LDL cholesterol, right? And we've all been told, and you've heard it from your family doctor, you've heard it from your cardiologist, that LDL cholesterol is bad cholesterol. It is harmful. It turns out that that is only partially true because LDL cholesterol isn't one thing. LDL cholesterol is actually a family of what we call lipoproteins, particles that transport cholesterol around in our bloodstream. And broadly speaking, there are two types of LDL cholesterol particles. There are what we call small, dense particles, and there are what we call large, buoyant or large, fluffy particles, you'll hear them called. And those are actually are very different things because the small, dense particles, these do get involved in plaque formation. They are what we call atherogenic particles, meaning that they promote the formation of atherosclerosis, the plaque in the arteries. But the large particles, the large buoyant particles, are non atherogenic. They don't get involved in plaque. So, insulin resistance, one of the effects of it is that it causes more of those small, damaging atherogenic particles and less of the large, healthy, non atherogenic particles. And that is a third way that insulin resistance ends up contributing to plaque formation. So those are probably the three big ones. There actually might be even a few more that we can point to. Insulin itself, the high level of insulin itself, some studies have suggested is also toxic to the endothelium, the blood vessel wall. That is why we see such a strong connection between insulin resistance and heart disease.
You hear this term too, oxidized LDL. Is
Mhm.
that tied to the small dense?
It is tied to it. It's not quite the same thing, but there is sort of a linkage there. Oxidized LDL is another form, essentially, of dysfunctional LDL. So, um, small, dense particles are more likely to become oxidized, is really the connection there. But it's a different type of damage that's being done to those LDL particles. And again, the problem becomes now. So we're going to take another step back and we're going to say, well, why, you know, why is cholesterol, why does cholesterol exist in our bodies, right? What is its purpose? And one of the purposes of cholesterol in our bodies is it is a repair mechanism. So when we get damage to the blood vessel wall, cholesterol is sent there to repair the damage. And what's supposed to happen when you have the large, buoyant cholesterol particles, right? They go, they repair the damage to the wall, they get sort of reabsorbed and they disappear. And there's nothing left behind. You have a nice new, wall. The small dense particles and the oxidized particles, when they go to the blood vessel wall and they're trying to repair the damage, but because they themselves are dysfunctional and damaged, the body reacts negatively. And now this small dense LDL particle that was there to try and fix the damage, it ends up magnifying the damage. It sets off its own inflammatory reaction, and you get things like macrophages that come in, which are cells that, are now trying to get rid of the small dense particles, and everything becomes kind of inflamed and it becomes this vicious cycle. And that's what is ultimately causing the plaque to build up.
Let's walk through life cycle of plaque. From the beginning, I know there's soft plaque, hard plaque.
Yeah.
I believe the soft plaque is the initial and then eventually it becomes calcified and hard. But take it right from the beginning and then we'll talk about best case scenario.
What you just said is a very commonly held belief, right? That we kind of start with soft plaque and over time it becomes calcified plaque. The reality is that we haven't quite proven that yet. And the reason brings up another important concept around heart disease. Understand that up until very recently, and I'm talking like the past 5 to 10 years, um, the only way that we would see plaque in the blood vessel, right, was either an autopsy was being done, right? Someone died, we opened up their blood vessels, we see what's going on in there. Or someone like myself, a surgeon, is going in there to operate on a blood vessel, right? And we open up the blood vessel and we see plaque. Now, neither of those things get repeated, over and over again throughout someone's life, right? The autopsy is obviously only a one-time thing, and even surgery like I do, right? It's rare that we're doing it, repeatedly on patients. Um, we didn't, up until very recently, have a good way of looking at plaque in people's arteries in living people and being able to do that, year after year after year, right, on a serial basis. We now do have very high fidelity scans of the heart that we can do, that we can actually start to see the plaque. So a lot of our understanding around, soft plaque, calcified plaque, has to come from animal models, and we really don't have a perfect animal model of plaque. Other observations come from, okay, we sometimes end up doing autopsies on young people, and this is what we see in their blood vessels. And then we do autopsies on older people, and this is what we see in their blood vessels. And so, the thinking is, well, it's an evolution, but it might not be as clear as that. So, yes, you are correct. There are two types of plaque, again, broadly speaking. There's what's called non-calcified or soft plaque, and there's what's called calcified plaque or hard plaque. And it does seem that the older that people get, the more likely they are to get calcified plaque. And when you look at young people, they generally don't have calcified plaque, but they may have some of this soft plaque. So there may be a time component to this. It may be that soft plaque does turn into calcified plaque over time. But again, we're only now starting to get very good data around this, because now we do have these high fidelity scans that I can scan someone today and I can scan them a year later, and I can see with great detail, this is where plaque was, and it was soft plaque, and now maybe it became calcified plaque. But that doesn't seem to be always consistent. There may be other factors that cause calcified plaque to form sort of primarily, and non-calcified plaque to occur in other situations. And it may not be quite that one always turns into the other. We're starting to see patients in my practice, for instance, that they have calcified plaque, and then we scan them a year later, and the calcified plaque starts to disappear, which is a concept that wasn't really understood previously. And so we're starting to understand all of this plaque dynamics. But ultimately, there are two types of plaque. We can say that for sure. These plaques tend to behave a little bit differently, right? So the danger coming from this plaque are probably different. When we're dealing with soft plaque, there is a concern that soft plaque might be unstable. It might start to peel off the blood vessel wall, and this can set off a blood clotting response and lead to a heart attack, what we call plaque rupture. Calcified plaque, it starts to make that blood vessel more stiff, right? And it can't expand like it's supposed to. And it can start to sort of gradually choke off the blood vessel as that calcified plaque builds up. And the reality is that most of the time when you're looking at plaque in people's arteries, these two coexist. When you look at an area of plaque with these high fidelity scans, you're oftentimes seeing combinations of soft plaque with calcified plaque. So imaging has become a very important tool that we can now use as we're trying to figure out heart disease for people, as we're trying to prevent and reverse heart disease for people. And this is really, I think, one of the things that over the next 10 years is going to vastly change how we approach heart disease. The fact that we can now dynamically see in living people what is happening with their arteries is really going to change our understanding of, you know, how things work when it comes to heart disease.
Somebody that wants to use one of these new tests, see where
Yeah.
they're at, what do you recommend?
I typically recommend starting with what's called a coronary artery calcium scan. This is a simpler version of the imaging. It's only looking at the calcified plaque in the heart, which is a limitation of it. But it is a easy to perform scan. Literally takes like 2 to 3 minutes. You don't have to put an IV in. You just lay down on the CAT scan machine, and you go in and you come out, and we get to see, is there calcified plaque in the arteries of your heart? And this turns out to be a great screening test, right? I oftentimes, draw the analogy of the mammogram, right? And we're trying to see the disease, heart disease versus breast cancer on the mammogram at its early stages. And that's what, if we see calcified plaque, we know that you have already started this progress towards heart disease. And if we see a lot of calcified plaque, it tells us you might be far along in this process and we might need to be worried about you. So that's where I usually start. Coronary artery calcium scan, like I said, very easy to do, inexpensive. Most areas, $100 to $200 to get a coronary calcium scan. And I now advise all men, by the time you're 40, get your first one. Women, by the time you're 50, get your first scan. If you have reason to be concerned, if you are metabolically unhealthy, if you are insulin resistant, if you are diabetic, if you have a strong family history of heart disease, get the scan even earlier. Because the reality is that I have 30-year-olds ending up on my operating table these days. And that means that that disease started in their 20s, maybe in their teens. And so, screening earlier can be helpful in certain situations. And then those high fidelity scans that I was talking about, they're called CT angiograms. Now, these are a little bit more complicated. We need to put an IV in you. We need to give you dye through that IV. The radiation exposure is higher, and the expense, they cost more money to do, especially the kind of latest version of these that use AI technologies to analyze the pictures and analyze the plaque. These things are still somewhat expensive and they involve more radiation and they're more complex. So I reserve that as the second level. If your CAC score is concerning, we might want to get a CT angiogram. If you're having symptoms of heart disease, we might want to get a CT angiogram, but it's generally not the first test that I recommend to people.
How often are you scanning somebody, man or woman, middle-aged, and finding no plaque?
The statistics are for a 40-year-old male, you're going to have about a 60 to 70% zero, 60 to 70% are going to have a zero score. When you're a 60-year-old male, you're going to have 30 to 40% with a zero score. So it kind of inverts there. Women tend to lag about a decade behind men when it comes to heart disease. So, 50-year-old women are going to tend to be more in that, 60 to 70% are still going to have a zero score. And by the time you get to about 70 years old as a woman, you're probably down into the 30-ish percent zero score.
When it comes to hard plaque versus soft plaque, let's branch off and do each separately.
Yeah.
Is there any chance there for reversal?
I think for both, the answer is yes. I think probably soft plaque, there's more chance than the calcified plaque. But I have patients in my practice now that we are seeing their amount of calcified plaque decrease. Their coronary artery calcium scores are going down. Now, I'm always realistic with people. Let's say you have a CAC score of 500 or 1,000. It's not going back to zero. It might go down 10, 20%. Uh, the natural history, okay, so coronary calcium scans, these have been somewhat prevalent for, 20, 25 years now. So we do have good studies looking at the sort of natural progression over time. And on average, coronary calcium scores tend to go up by 10 to 20% per year. Um, when patients don't progress that much, if they only go up 5% or they go up 0% year over year, we know that that puts them into a low risk category. That patient is unlikely to have a heart attack in the intervening couple of years. So the progression over time becomes an important predictor of the disease. And like I said, we are now starting to demonstrate plaque regression, lowering of both calcified plaque and the non-calcified plaque, because now we have patients that have gotten CT angiograms, the higher fidelity study, on a serial basis, a year or maybe 2 years apart, and we can see both types of plaque can reverse. But I always tell people, as long as we have stopped it from getting worse, as long as it's not continuing to progress, that's sort of what victory looks like to me.
The $1 million question, somebody that gets reversal, what
Yeah.
are you having them do?
Yeah, so all of the things that we've talked about and maybe a little bit more. The primary things we need to do are reverse your insulin resistance if it's present, lower your inflammation if it's present, and we need to optimize the quality of your cholesterol, right? That's not the same thing as saying low cholesterol levels. That's getting mostly large, fluffy LDL particles, little of the small dense particles. That's making sure your HDL cholesterol is high and your triglycerides are low. And we do the advanced measurements. We look at those particle sizes routinely in our patients so that we know what we're dealing with. So lower insulin resistance, lower inflammation, optimize your cholesterol quality. Those are probably the three big pillars. There might be some other things that help. There are some supplements that people talk about, like nattokinase, vitamin K2, nitric oxide, we talked about earlier, right? And if people are low in nitric oxide to start with, then you might want to do something to boost their nitric oxide. That can be something, by the way, like going out in the sun, exercising, right? Those are ways to raise nitric oxide. Or it might be something like taking a supplement that might help you raise your nitric oxide level. So all of these things can start to come into the picture. But again, it all starts with get rid of insulin resistance, get rid of inflammation, and optimize the quality of your cholesterol. And that sets the stage for stabilization at first, stop it from getting worse, and then give the body a chance to heal, and let's see some improvement.
When it comes to a carnivore diet and nitric oxide, how does that, if it does, help with production? Because you often hear eat beets, certain plants can boost it,
Yep.
but talk about it from the carnivore perspective.
I think the way that carnivore really promotes higher levels of nitric oxide is by removing a lot of the things that are damaging, you know, nitric oxide, right? The insulin resistance, the processed foods, the pro-inflammatory foods. So that is one of the things that that is probably the primary reason. Um, um, are there specific components of meat that help make nitric oxide? Yes, there probably are, right? The precursors, right, that our body uses to make nitric oxide, a lot of these things end up being available in meat. Are there some plants that have these things as well? Yes, there are. But again, we could probably get all that we need from the meat. And if we're eliminating the things that are hindering our production of nitric oxide, that becomes a big advantage as well.
You quickly mentioned nattokinase.
Yes.
Explain the mechanism and how that fits in.
Yeah, so nattokinase brings in a whole different aspect of plaque formation that actually we didn't get to uh, talking about today. Um, and that is um, blood clotting. So it turns out that one of the other things that contributes to plaque formation is we start to get they're kind of microscopic blood clots that form. And those can start to contribute to the formation of plaque. And so nattokinase uh, primarily works on the blood clotting system. It increases what it actually does. It's interesting. It doesn't necessarily stop the formation of blood clots, but once a blood clot starts to form, nattokinase increases the body's ability to get rid of that blood clot. That's why nattokinase has been shown to potentially be helpful in reducing plaque formation, or even potentially helping with existing plaque to lessen. There are some studies that have pointed to this. There might be some limitations to these studies, like they always are, but ultimately, nattokinase has been shown in some trials to help reduce the amount of plaque. Those trials were primarily looking at plaque in the arteries of the neck, not necessarily plaque in the arteries of the heart. But, again, mechanistically, one of the ways that nattokinase is working is by helping the body to break down blood clots so they don't persist and turn into plaque.
When it comes to blood clots, I just want to make the connection there with the plaques.
Yeah.
The way I understood it coming into this is the soft plaques, when they rupture, that's when you get a blood clot. Do I have that right?
So that is one of the situations where you're going to get a blood clot. And those are kind of the bigger blood clots that are actually going to block up the blood vessel and cause a heart attack. But at a microscopic level, again, when we have that damage to the blood vessel wall, right, blood clots become part of, again, that healing mechanism, and starting to fix the blood vessel wall. And those are the kind of microscopic blood clots that the nattokinase really helps to target, so that those blood clots don't become persistent and ultimately contribute to the plaque formation. It's interesting when we look at plaque under the microscope, right? And we see the cholesterol that's there. And one of the hypotheses that has been put forward, right? Understand that our blood cells, all of our cells, but our blood cells being relevant in this aspect, the lining of the blood cell, right? The wall of the blood cell is made up of cholesterol. So, one of the ways that the cholesterol might end up in the plaque is not that it's that the cholesterol that's circulating in our bloodstream. It's that we started with a blood clot, right? We had the red blood cells, the platelets, in that blood clot. Those broke down, and what was left behind was the cholesterol from their walls. And so, that is one of the lines of evidence, that starts to connect blood clotting to plaque formation. And that is one of the reasons that we think things like nattokinase or aspirin is another example, right, of a anti-blood clotting agent that has been demonstrated to help reduce the incidence of heart disease.
One thing that comes up for me as you share blood clots and getting rid of those, reversing plaque, whether it be through nattokinase or something else, is poking the sleeping bear. And if things are stable, starting to tinker with that and potential problems that could arise. Any thoughts on that?
Well, yeah, there's always balances, right, in everything that we do. There's always risk and benefits of any intervention that we're thinking of. So, something like blood clotting, you want to find that right balance, right? You don't want to overly impair the body's ability to blood clot, because that's to clot, because that's going to lead to other issues. And you certainly don't want to be overly promoting blood clotting, right? That's going to lead to certain issues. And it really, the concept in physiology in general, right, is about homeostasis, finding that right balance between too much and too little of a lot of these processes.
So you went over a couple of different tests we can have done to look at plaque. Let's talk about blood work. Somebody going to get a lab panel,
Yep.
and they say to you, Dr. Ovadia, cost isn't an issue here. I want to get a full workup. What would you have them do? And what would you really look at?
Mentioned it earlier. Insulin resistance and inflammation. These are the two big ones. And then the quality of your cholesterol. So, what's involved with that? Insulin resistance, there are a couple of different ways that we can test it, but the easiest and the one that I usually start with is let's look at your fasting insulin level. How much insulin is in your bloodstream when you haven't eaten for 8 to 12 hours? We want that to be under 10, in the single digits, ideally under 8, I tell people. We can also use that if we've tested your fasting insulin and we've tested your fasting glucose sugar level. We can plug those two numbers into a calculator. It's called the HOMA-IR score, HOMA hyphen IR. We can, that is one way that we can measure how insulin resistant people are. Inflammation, the main measure we're going to look at there is called HSCRP, C-reactive protein, high sensitivity C-reactive protein. And this is going to give us an indicator of kind of total body inflammation levels. That's another one for us to look at. There are some other relevant inflammatory markers that I usually bring into my blood panels, things like uric acid, things like ferritin. And then there is a blood vessel specific inflammation marker that we can check called myeloperoxidase. And this gives us an indication of, are the blood vessels actively inflamed, which is going to correlate with plaque formation. Cholesterol quality, right? So this is pillar number 3. On your basic lipid panel, you get your HDL cholesterol, you get your triglycerides, you get your LDL cholesterol level. Does not tell you about the quality of the cholesterol. It only tells you about the amount of cholesterol. You want to get what's called an advanced lipid panel. It might be called an NMR panel or a lipid fractionation panel. And this is going to break down what type of cholesterol do you have. The LDL specifically, is it large or is it small? And so that is a test that I recommend to everyone. We mentioned homocysteine earlier as an indicator of methylation problems. Get that test done. Probably the last kind of piece that oftentimes gets missed is something called lipoprotein A. This is a special form of LDL cholesterol, and it has an extra protein attached to it. That's where the name comes from. Lipoprotein A is the extra protein that's stuck onto that LDL molecule, and it makes LDL sticky. It makes it interact with that blood clotting system that we were just discussing. And so patients that have elevated lipoprotein A levels are at increased risk of heart disease, having nothing to do with the cholesterol, but having to do with that blood clotting system again. So those are, I think, the high points of the blood panel that I get from my patients. And it turns out it's not super expensive to do that. It's going to cost you a couple $100, but I think it's a good investment in your health to do that a few times a year. Your insurance oftentimes will cover a lot of that. The challenge for most people is getting a doctor who understands these tests and will therefore order them for them. And that's where it becomes a little bit more difficult for most people.
I'm glad you brought in LP little a. I wanted to get into that.
Yeah.
The way I understand it, that one is heavily genetic based, and having one test done is often sufficient to see where you're at. Do you agree with that?
Sometimes. So yes, it is heavily genetically influenced. If you get an LP little a test and your LP little a level is normal, you probably don't need to keep retesting it. Maybe you do it again, 5 years later, just to make sure that it wasn't an anomaly. If your LPA is high, yes, it's going to probably stay high for the rest of your life, but we do see some influence of diet and lifestyle. So I've seen LP little a levels come down when people resolve insulin resistance by, 10, 20, maybe even 30%. And that's where I do tend to actually retest it. In those situations, I want to see what's happening with it. But yes, largely genetically determined. If it's high, you want to maybe take some extra protection against blood clotting. So this might be a situation that would push someone more towards using something like nattokinase, using something like aspirin. And you also want to be alerted to the fact that you're at higher risk of heart disease. So you might want to be more aggressive about getting those imaging tests, for instance, to see, what's the impact of the lipoprotein A.
Okay, so nattokinase, reverse insulin resistance. If you yourself were in that category, anything else you'd add in there?
I guess the other things I would talk about, the general pillars of health, making sure you're getting a good amount of activity, making sure you're sleeping, right? Making sure you're getting out in the sun, those dealing with your stress, right? Those are the other things that I would throw in there that we know can contribute to this as well.
How do you think about ApoB? Is that a test you like to even look at?
So, ApoB suffers from the same problem that LDL cholesterol levels do. You're looking at the amount of cholesterol, but you're not getting insight into the type of cholesterol. ApoB measures both the large LDL particles and the small LDL particles. It also measures something called VLDL particles, which are also atherogenic. And that's why ApoB ends up being a better test than LDL alone, but you still have the same problem. If your ApoB level is high, um, you don't know. Do you have a lot of the large particles that are not harmful and therefore that high ApoB is not going to be problematic? Or do you have more of the small particles which are harmful and it's going to be problematic? Now, you also see the opposite problem, or I see the opposite problem. ApoB levels, LDL levels can be what are considered low. Maybe you're on medication to do that, maybe you're not. But you could have primarily small particles and you are still at risk. So this is the reason that, again, I don't like relying on the ApoB alone or the LPL or the LDL alone. I want to know what type of particles we're dealing with.
Last question for today. I want to talk about hope.
Yeah.
Somebody who is middle-aged, they haven't been applying what we've been talking about today. Maybe they know they have plaque, maybe they assume, but they're feeling like, okay, half my life's gone by. Do I have a chance here with being preventative? What would you say to them?
I would say definitely so. What I always tell people is it's never too early to start this, but it's also never too late to start this. We now have in my medical practice 80 and 90-year-olds that are doing this and they're doing great with it. Even if, let's take this a step further. Let's say you've already had the heart attack. Let's say you've already had a stent placed. You've already had bypass surgery. Um, we still can do the same thing. We can stop it from getting worse and we can give the body a chance to heal and start to see some improvement. So, never too late to start this. I am all about patient empowerment and giving patients hope. And that's what I think this is all about. Heart disease is not inevitable. We do not have to accept the fact that heart disease remains the number one killer year after year after year. We do not have to accept the fact that 750,000 Americans die of heart disease every year. I am on a mission to change that. I am on a mission to give patients back the hope and say this is a preventable disease. And if you get aggressive about it, if you are proactive about monitoring your level of disease, and let's stop it from getting worse and let's try and get it better, we are going to change, what is thought to be destiny. You can do something about this. You, the patient, you are in control. And let's give you back the hope and let's give you the tools that you need to keep you ultimately from having heart disease.
Love that. Perfect place to end it. Dr. Ovadia, we're going to link up the new book, your YouTube channel, social media, website, everything in the show notes. Loved round 2. Far-reaching conversation. We covered a lot. I appreciate you. Thank you.
Great seeing you as always, Jesse.
Thanks for watching the episode. I got another great one lined up for you right here. Don't miss it. I'll see you over there.
Visceral fat is pathological always. It should never happen, but we have an epidemic of it going on right now. Estimates are anywhere between 40 and 50% of the population may actually have fatty liver.